Yes. Hello, everyone, dear colleagues and friends. I hope everyone had a fantastic time presenting today for the second round of Megamind. You guys saved me for the very last. I hope I can be as amazing. I've watched every single presentation. Everyone was fantastic. So thank you, Megamind. Thank you, Megagen. And of course, thanks, Mark Wan, Bytes Institute for this fun event and encouragement to participate this year. I'm super stoked for everyone and wishing everyone good luck. My name is Dmitriy Ivanov. I'm a board certified periodontist from Redondo Beach, California. My topic today will be on the tissue will always be an issue, especially with the management of complications. And we've seen a number of the complications today, which were beautifully managed. I want to just start with a famous quote by an American astronomer and scientist, Garrett Service. He said that science does not ostrich-like bury its head amidst perils and difficulties. It tries to see everything exactly as everything is. Simply put, if the surgeon says that he does not have a complications in his practice, it's probably because he doesn't do enough surgery or he's lying to us. So I wanted to start with that. Sharing our own complications is something we learn from. Before we jump into talk about a case in clinical work, I would like to review a few basics. This concept of restoratively driven implant therapy, we all know what it is. It simply means that the case treatment planning should always start with an ideal restoration in our mind. And this concept is true across multiple modalities that we've seen today. Posterior teeth replacement of full mouth rehabilitation cases. It is especially important in the aesthetic zone where the room for error is so small. But to be able to practice this type of dentistry, we got to have good bone and good soft tissue. So before we get into before we are able to successfully develop hard and soft tissue case or procedure like what we just talked about, treatment planning and case selection is very important to us, which is a way of identifying specific risk factors. So a lot of risk factors, of course, are present. Again, we've seen many different risk factor discussions today. And understanding all possible risk factors is something that can make or break the case. And I think I want to make the presentation of my clinical case to kind of surrounding the thought of a variety of risk factors and how skipping on the risk factor evaluation can really break or make the case for us in the future. Some of the risk factors we obviously can modify. We can grow the bone predictably, we can grow soft tissue predictably, but if we have for example, a loss of attachment on an adjacent tooth, it is very hard to recover sometimes. And if an implant has to be placed next to it, it becomes a big challenge aesthetically as well as surgically. We can also sometimes, where we cannot, or also sometimes modify certain patient factors. For example, if patient smokes 2 packs a day and not willing to change, we can't do anything about it. Or patient that has been on IV bisphosphonates for a number of years. So certain things we have to be able to modify, certain things we have to be able to avoid. And let's jump and discuss our case. This is a 68-year-old male who was referred from a general dentist practice after a failure to extract the tooth. They were working very hard, broke a piece of the root that was left in place. Overall healthy patient, non-smoker, no history of periodontal disease, all probing depths under normal, no inflammation. Some poor plaque control since the extraction. They made him some sort of an Essex retainer to wear, so he wasn't able to manage this. But overall, pretty good, pretty well-maintained patient. The tooth was needing an extraction because of failed endodontic treatment. His chief complaint was, I would like to replace a missing tooth. So let's take a look at some of the risk factors. Obviously, we're deficient in a volume of bone. Volume of bone and soft tissue. We also have slight papilla loss and very much thinning of the papilla. There might have been some trauma. The big thing here to note is there's still a dehiscence, a probable dehiscence that leads into a piece of the root that you can still feel inside. So, and the patient has a pretty high smile line, which is fairly, on the aesthetic risk assessment, is a high risk patient for us. So generally speaking, in a case like this, I would treat this with just a conventional, basically the way I treat sockets with a buccal bone missing. And this type of case, because the soft tissue overall quality was great, very good phenotype, nice zone of keratinized tissue, I didn't think much about this at first, especially the dehiscence that was present. So we removed the remaining root that was present. we cleaned the defect and we prepared it for just the conventional socket augmentation. There was a dehiscence, but it was a very nice piece of bone that was still remaining there. We augmented the site. This was just augmented with a ridge augmentation type procedure using Osix Plus membrane and glycolon internally stabilizing sutures. This is a mixture of autogenous bone with allograft in a sticky bone form, which was stabilized again internally with Osix Plus membrane. And flap was advanced, nothing very out of ordinary, just a simple closure. The dehiscence was just approximated with the sutures. Again, I did not think much about anything that might go wrong because it was a very tension-free closure. I was not preparing for any complications, but 2 weeks later, unfortunately, we ran into a very big problem. Patient comes in, there is no pain, but we see a complete dehiscence of that distal area of the flap and complete loss of the papilla. This is the membrane that's exposed at this phase. We simply manage this non-surgically. We told the patient we will need to reevaluate since there is no infection. We manage this case every week to make sure that the patient is stable, and this is how we presented at 2 months. So basically, we starting with a new set of risk factors that we have to reevaluate, the more drastic risk factors, but nevertheless, we're at the drawing board again. Bone tissue deficiency. Now we have a bigger problem with the defect present on the root surface with the attachment loss on the facial and the proximal. We have thin tissue at the crest, and again, high aesthetic risk. We have a higher smile line, so we have to plan for the next step. So we're going back to the drawing board and discussing option with the patient. Obviously, this tooth is very stable periodontally. It is not going to be needing an extraction. There's no mobility, a very long root. So we go over options with the patient and discuss the possibilities a future result. Basically, patient has to be let know that these type of defects may never end up ideal. And this patient was very realistic. He accepted the treatment plan with the notion there might be a need for a multiple soft tissue and bone augmentation procedures. So because of the attachment loss, we wanted to take advantage of possibly regenerating some of the attachment. We used a conventional GBR approach here and using a little bit of a GTR approach with some endogain application on the root surface. This is again Osix Plus membrane stabilized with the glycolon sutures. But at this time, I was trying to omit or avoid the same complication that happened in the dehiscence. We decided to augment the soft tissue, both protecting the flap as well as starting to develop the soft tissue in the papilla area. This is a pedicle connective tissue graft, also known as a VIP CTG graft. Why did I choose that? Because that graft comes with the blood supply. It's the only graft that usually maintains the entirety of its volume during the healing process compared to like a free connective tissue graft, which tend to shrink to a certain degree. Our closure is very similar to a GBR approach. We are advancing tissue as coronal as possible. As you can see, I will show you how I stabilize these type of grafts internally in just a few seconds. I usually give this time at least 6 months to heal because that's how long it will take for the bone regeneration to happen. But at this point, we're going to ask ourselves a couple of questions. First, do we have enough bone? Well, we took a CT scan. We are going to take a look at it in a second. But the more important question is, how is our soft tissue? Well, if we take a closer look, there is still recession present on the tooth mesial line angle. There is still deficiency in the papilla area, although the defect had corrected quite a bit. So what I told the patient, we're going to place our implant because our bone is ready. We're going to open and take a look at it, but we're also going to be doing additional soft tissue augmentation using another VIP connective tissue graft. So we open our flap with the notion we're going to be designing our flap with the papilla in place and a full thickness on the site where we're going to be augmenting. We're going to place our implant 3 to 4 millimeters apical to the proposed gingival zenith for the emergence profile in a screw retained position. This is a great view to show the difference in the peaks of bone, which is why we have a defect there. The design was a full thickness up to the mucogingival junction and a split thickness right at the mucogingival junction to allow advancement of the flap, but also stabilization, which we will be using for additional grafting. This is a A second VIP connective tissue graft is a pedicle graft that came from just the local area. And this is addition of a tuberosity graft, a very thin layer that will create a very beautiful, thick gingival margin for the area of recession for the long-term maintenance. Both of these have been stabilized independently. I like to call this a scarf technique because the key to a VIP CTG, it has to hug the root of the tooth very, very nicely without any dead space right here. Then we advance the flap similarly to a GBR. This time we're going even more coronally because again, we're trying to get as much tissue height against the root as possible to get that attachment level higher to regenerate the papilla. In these type of cases, 2 months is sufficient for the blood supply vascularization of this graft. So we are now 2 months into the healing of the implant and 2 months into the healing of the soft tissue. So we're now ready to start developing the tissue emergence profile with the temporary. I always temporize the aesthetic zone cases myself. We simply expose with the biopsy punch. I use a 15C blade to remove a small core of tissue and create a very narrow emergence profile. Subgingival contour has to be extremely narrow, not to put too much pressure laterally. We're only putting pressure in this critical zone to create adequate zenith position for the future restoration. But proximally, we want to leave as much space as possible, always leaving a lot of space. It appears that there's some push of the papilla apically. Not to worry, everything is very concave inside, so we should be able to recover that papilla. It's going to start growing. I also took advantage of that time formed after the surgery to kind of improve the aesthetics of the case. And we gave this time about 3 months, or in this case about 3 months to mature. We took off the provisional at that time, and now we can really appreciate the soft tissue development. We can appreciate the width of a keratinized gingiva. We have a beautiful tissue in a horizontal connective tissue dimension and a vertical dimension. All of this I call a blueprint for an ideal restoration. We covered basically all bases. We have good bone, we have good soft tissue surrounding the implant. The implant is in the proper position, so we are ready to take a final impression. I always use a custom impression coping because I want to transfer the information that I've created for the soft tissue into the lab. When lab makes me a restoration, I do not want to see any more blanching because we're not changing position of the tissue at this time. This is the delivery on the final visit. Let's look at the crestal bone level. Crestal bone level was very stable and aesthetics were quite good. Patient was extremely happy. He's been without a tooth for over a year and 3 months or a year and a half almost. This is a 1-year follow-up, 1 year and maybe a month. We just saw him 2 months ago for the recall. He's improved his oral hygiene overall. The tissue was quite stable, extremely functional, very nice contour of the restorations. Although we do have some soft tissue defect there approximately. The crestal bone level, this is an x-ray after a year and function, also quite good. Actually, there's some more notable cortication that was formed compared to the initial delivery of the prosthesis. So again, comparing the before and after, where we started with a big disaster to this full recovery, or at least a part of full recovery of the facial tissue and partial recovery of the papilla, patient again is extremely happy. This is the smile line, and we had a very challenging time matching the shade. As you can see, there's so many different chroma and shades and colors, but patient is extremely happy. Now that's what really mattered to us, that we were able to deliver. As final thoughts, treatment planning and case selection is always key. That's depending on your experience. ID every risk factor possible before starting the case, and do not ever hesitate to stage the case. As you can see here, one issue cover and heal for 2 months and then come back to do my bridge augmentation. I think we would have been in a much better situation without worrying the patient too much. In complicated cases, plan more but do less. And tissue training in the aesthetic zone is a must. We cannot bypass the provisionalization of tissue in the aesthetic zone. It's just simply impossible to do. And then as a risk, if we do these type of cases, we have to assume a certain risk because complicated things will have more complications to deal with. We just have to be prepared for it. I wanted to thank everyone for your attention for these last 2.5 hours. You guys were listening to us speak. I wish everyone best of luck. If you have any questions, my contact information is my email here, and my Instagram account is perioimplant_LA. Thank you.